start my presentation entitled A Novel Fixed Dose Combination for Allergic Rhinitis. So after the end of this presentation, we'll be able to understand the epidemiology of allergic rhinitis, impact of lifestyle, and pathophysiology of allergic rhinitis, guidelines recommendation on management, rationale for synergistic combination, components of combination, mechanism of action, pharmacokinetics and dynamics, and safety profile of different anti-allergic drugs, literature on combination, and little bit of clinical experience. So what is allergic rhinitis? Though it's very common in our clinical practice, it's very, very important, as defined as an inflammation of the nasal mucous membrane caused by reaction of the body to the allergen. And it is a multifocal immunoglobulin E-mediated type 1 hypersensitivity reaction. Allergic rhinitis is the most common type of allergic disease in clinical practice. And it is 10 to 30% of the adult and up to 40% of the children suffer from allergic rhinitis. So it's a global overview, shows 30 to 40% the allergic condition, and high proportion of young stars are suffering from allergic rhinitis. So as a ENT surgeon, allergic rhinitis patients are coming, but along with them, other comorbid condition, they are coming with that. So these are upper respiratory tract infection, recurrent URTI, nasal polyposis, otitis media with effusion, asthma, sinusitis, etc. So what are the symptoms in our clinical practice? These are the symptoms. Snoring is an important issue in day-to-day practice, especially childhood obstructive sleep apnea, headache, congestion due to sinusitis, sneezing, rhinorrhea, congestion, nasal drip, otitis media with effusion, and some ocular symptoms, they are coming with that. So epidemiology, over 600 million people worldwide are affected by the allergic rhinitis, and 1 in 6 people suffer from allergic rhinitis. So allergic rhinitis developed before the age of 20 years in 80% of the cases. In India, allergic rhinitis comprises of 55% of allergy sufferers. So it's a huge impact and huge burden in our society. And 20 to 30% of Indian population, we can think how much the burden of allergic disease. So one survey was there, allergic prevalence survey, and it is seen that India is the top 10 countries having highest prevalence of allergic rhinitis. So impact of lifestyle is very, very important. 57% of the people with allergic rhinitis have troublesome sleep at night because of obstructive sleep apnea, especially children. And each year, almost 3.5 million work days are lost due to allergic rhinitis. So absent from school and huge medication cost to the patient is also very important impact on lifestyle. So if we go the pathophysiology or pathogenesis of allergic rhinitis, it has two phases. One is first exposure and second exposure. What happened? But there are different types of allergen, right? Aeroallergen or ingested allergen, whatever may be, like pollens, animal denders, dust mite, house dust, whatever may be. They sit on the nasal mucosa, and antigen presenting cell process the presenting allergen, that is the antigen, and they form B cell, and from B cell they secrete immunoglobulin E antibody, and this immunoglobulin E antibody sits over the mast cell. When subsequent exposure of antigen, this antigen antibody complex form, and there is a degranulation of the mast cell, and there is a release of different mediators, that is called primary and secondary mediators. So if we divide phase-wise, phase 1 sensitization and phase 2 sensitization. So allergen, antigen presenting cell, they process the antigen and they convert into CD4 T cells and T cell, and that is called plasma cell. From plasma cell, immunoglobulin E secrete. This immunoglobulin E antibodies sits over the mast cell, and subsequent exposure of allergen, they degranulate, and there is a mediators for primary and secondary mediators. So histamine is the main key mediators for allergic rhinitis or any allergic pathology. So what it does, it leukocyte activation, bronchoconstriction, mucus secretion that leads to rhinorrhea, vasodilation and edema leads to nasal congestion, nerve stimulation that leads to itchiness, sneezing of the nose, and leukocyte proliferation and phagocytosis. These are the effect of histamine in the pathophysiology. So if we see that there is two phases, we have discussed early phase and late phase. What happened? This is the key mediator is the histamine, and next is the leukotrienes. So it irritates the nerve ending, as we have discussed, that forms the early phase of allergy that leads to sneezing, itchy and running nose. And in late phase, that the leukotriene, it causes nasal congestion and inflammation. So two factors of allergic rhinitis, one is seen and unseen. We can see in clinics, in our clinic, so patient come with sneezing, congestion, running nose, itchiness, short throat, postnasal drip, redness of the eyes, watering of the eyes. Some unseen condition like huge adenoid is a factor that leads to obstructive sleep apnea. Huge turbinate hypertrophy or mucosal edema that leads to osteometal complex block that leads to sinusitis. So concept of minimal persistent inflammation is the main concept for underlying cause of chronicity. An inflammatory process which is actually present, them says a symptomatic person exposed to allergen. So minimally persistent inflammation is the main root cause for chronicity. So nasal congestion is the most common. There are different studies shows that 97% are suffering from running nose, and nasal itchiness is the 88%. There was study conducted in Delhi. So there are two groups. They have divided sneezer and runners and blockers. And nasal blockage is the most bothersome and prevalent complaint in our day-to-day practice. So sneezer and blockers, two categories, and significantly more blockers had a moderate and severe persistent type of allergic rhinitis, whereas both bronchial asthma and sinusitis are more significantly common among blockers. So two groups we can divide in our clinical practice. So these are the area guidelines. I'm not going detail about as a ENT surgeon, we all know this area guidelines, but this is the protocol we follow in our day-to-day practice. Initially, allergic rhinitis was divided into perennial or seasonal. Now we divide according to the area guidelines, like intermittent and persistent. In intermittent, mild, moderate and severe, and in persistent, again mild, moderate and severe. This is the flow chart we follow for treatment protocol. So if we compare, there are different categories of anti-allergic drug in our hand. One is corticosteroid, one is antihistamines, anti-leukotrienes, anticholinergic, decongestant. If we compare different pharmacology, different effect on our system, if we consider corticosteroid is the best. They taken care all the symptoms. And antihistamine, yes, this also very good, very nicely control all the symptoms of allergy. Anti-leukotrienes, yes, if we compare, it's good. Anticholinergic in some cases like rhinorrhea is very is taken care by the anticholinergic, but decongestant only congestion part. So enhance therapeutic effectiveness by combining an antihistamine and anti-leukotrienes that will alleviate both as well as late symptoms of allergic rhinitis. So which antihistamine would be ideal? Older generation where sedation is a big issue for the antihistamine prescription in our anti-allergic treatment. Now in our hand, there is a second generation, safer, potent, have a quick onset of action, and that is bilastine. It's a novel, multifaceted second generation antihistamine with highest number of feature of ideal antihistamine as per different guidelines. So the ideal anti-allergic drug should inhibit both early and late phase of pathophysiology, be a very good H1 blocker, counter effects other mediators, fast acting, and to control early phase. And those should be it's a very good compliance. For the compliance, it's a OD or BD dose compliance, no side effect, and manage all symptoms. So if all the criteria fulfills, then it is a very good anti-allergic drug. So if we compare different drugs like bilastine, levocetirizine, fexofenadine, and desloratadine, we can highlight this point. H1 receptor selectivity is more in bilastine in compare with levocetirizine and fexofenadine. And other parameters like max and t-half is more in case of bilastine. And it's indicated in allergic rhinoconjunctivitis. Yes, pediatric indication. Yes, it is considered. No dose adjustment in renal impairment. It is very important point, because if we go pharmacokinetics, it not metabolized, it excreted through the renal pathway. So another dose adjustment in hepatic impairment not required, because it's not at all metabolized in the body. Dose adjustment in elderly, bilastine fulfills all the criteria. So all this point makes bilastine is a very good anti-allergic drug. So another drug we were prescribing for many decades, like one Montelukast, the only leukotriene receptor antagonist used in allergic rhinitis. It's highly selective leukotriene receptor antagonist, blocks leukotriene receptor, control late phase. As we have seen, the allergic pathophysiology, early phase and late phase, the mediators is the leukotriene. So it is another key mediator for late phase reaction. So that is also how it acts. This is the pharmacokinetics, how Montelukast blocks the cis-T1 receptor, leukotriene receptor. They block the inflammatory cells and different mediator secretion. So yes, this is the flow chart. We can see this is the histamine, the key mediator in early phase, and leukotrienes is the late phase. So bilastine blocks the histamine in early phase, and Montelukast blocks the in late phase. So control both sneezing, itchy, running nose, nasal congestion, inflammation. So combination therapy and dual action is very, very effective in early and late phase of reaction. So yes, this is the how the mast cell degranulate the histamine release, and they block the antihistamine, they block the antihistamine receptor. So evidence of pharmacokinetics and drugs. So